All right. Well, good afternoon, everyone. Thanks again for joining us on this Friday afternoon if you're on the East Coast, morning anywhere else. We're just really excited to have our colleague, Dr. Laura Lee Hall, who's the president of the Center for Sustainable Healthcare at the National Minority Quality Forum, do a presentation with the guy that's been working with us for years. I mean, Dr. Davidson has been an asset to the folks at NMQF, helping us in every therapeutic area that you can imagine. So excited to see them, hear from them today, and so you can learn a little bit about COVID-19, diabetes, and the vaccines. So without further ado, I'll turn it over to Dr. Hall.
Brandon, thank you so much. Thank you everyone who's joined us for this amazing presentation. I have the great honor of introducing Dr. Jaime Davidson, and it would take the full hour to do credit to his resume. He is a clinical professor of internal medicine at the University of Texas Southwestern Medical School. In fact, I'm not going to even read all of his positions and all of his accomplishments. Know that he is a leading clinician, a leading educator, a clinical researcher, and a researcher in other ways, not just clinical trials. He is a passionate advocate. He has been a leader in diabetes work for many years now, founding organizations, serving as leaders of many of our top endocrinology and diabetes organizations, and not just in the United States, but worldwide. So we're very lucky and excited to have such a distinguished person who has been a long friend to people, diverse populations facing diabetes. And he is extremely knowledgeable and been tracking the COVID implications for people with diabetes and now the vaccine. So with all my thanks and no further ado, Dr. Davidson.
Thank you, Dr. Hall. It is a pleasure to be here with you guys this afternoon or this morning, depending where we are. Brandon, thank you. And Keiko, thank you for all your help. You know, if we can share my screen, that will be great, so I can actually get going with my presentation. One thing I will tell you, you know, it is almost impossible to cover all the knowledge that we have, you know, on COVID-19 and diabetes to do it in this period of time. So Laura Lee asked me to actually give an update on COVID-19, diabetes, and people of color. And I want you to know that what I will tell you today, a month from now, may be a little different. We're going to have a lot more knowledge. So please stay tuned, okay? It looks like I cannot move it. Let's see. Okay, now I can. Okay, this is where I work. You know, the Touchstone Diabetes Center is in this building behind, you know, in the 5th floor. If you come to Dallas and, you know, once we get over this pandemic, you know, I would love for you to see our center. So this is my agenda for today. As you know, COVID-19 is the first pandemic of the 21st century. I'm going to talk a little bit about who is at risk, the prevalence, treatments, preventive measures, vaccines and minorities, which is quite important for us today, and then conclusions. So COVID-19 and the 21st century pandemic. So March of 2020, almost a year ago, the World Health Organization declared COVID-19 as a global pandemic. The first cases were reported in China, in Wuhan, province of Hubei, and from there to the rest of the world. And I tell you, I did a couple of mini sabbaticals in China, and I had the opportunity to address, you know, the Hubei province medical division, you know, on diabetes and Chinese, which They didn't have diabetes for a long time. Now they're getting a little overweight and they're getting a lot more diabetes. In the world, the most affected countries, and you can see is usually by size, is the US, India, Brazil, and Mexico. In Europe, it's Italy and Spain in the beginning, but most recently, Germany and England right now, which is in a lockdown, and France. So what is COVID-19? COVID-19 is a virus, and it's a virus of the Coronaviridae family. Their previous members to this family include SARS, which is known as Severe Acute Respiratory Syndrome, and MERS, the Middle East Respiratory Syndrome. The difference is COVID-19 started as one of the most contagious viruses ever seen. Now, in addition to that, we have now new mutations that have been reported in several countries, including Australia, the United Kingdom, and most recently, our USA. So what are these mutations? They appear to be more contagious, but not more virulent. And I put that at a question mark because that is what we were told by the CDC. The United Kingdom went on lockdown based on data showing that the new mutation is 70% more transmissible. Recent reports, including here in the United States, questions the virulence. It is actually more virulent than the original strain. And then the question I have is, are we missing data that has not been reported to us yet? So this new mutation is B.1.17, and that's the mutation that was detected here in the US. So this is the Wuhan, China, and as the province of Hubei. And the question I have is, from Wuhan to the rest of the world, here to the United States with cases that we could not believe, but from Wuhan to Beijing and Shanghai, it didn't happen. And I have no answer today. Let's move to who is at risk. All of us are at risk. There's no one here that is not at risk, but there are people that have a higher risk. Older adults, 65 years and older, no question. African American and Latino Hispanics are affected in disproportionate numbers. People of any age with underlying medical conditions. And one of them is uncontrolled diabetes. And you're going to see a lot more data about that. People with disabilities. People in nursing homes, long-term care places, and correctional facilities. Homeless shelters, meat and poultry processing facilities were affected drastically here in the United States. Actually, you will see some of the data because more than 50% of all the cases, are in that particular group. If we look at underlying medical conditions outside the US, this is Italian deaths. 73% had hypertension, 32% had diabetes, 28% have heart disease, 24% were patients that have reported arrhythmia, mainly atrial fibrillation, and 22% had renal insufficiency. So you start looking at that in Italy. Now let's move to the United States. New Orleans, Chicago, Detroit, underlying medical conditions, obesity, hypertension, diabetes, and chronic kidney disease. And when we look at these three places, New Orleans, Chicago, and Detroit, there was an excess of cases and deaths in the African American community. So you start looking, and we look at what are the causes of inflammation and who is more affected by COVID-19, and there is going hand by hand. What conditions cause inflammation that we know? Obesity, diabetes, hypertension, smokers, and we know that's a problem. People with cancer, any malignancy, heart disease, and the older we get, obviously we have more inflammation because of age. And COVID-19 actually is an inflammatory condition. What are these chronic conditions have to do with the immune system? It is known that patients with diabetes have a dysregulated immune system. And that's why people with diabetes that are poorly controlled have a lot more problems with infections, etc. They're more susceptible for that reason. But if we control them, the susceptibility to infection goes down. So type 2 diabetes has been associated with an increased ACE2 expression. And that is the transmembrane protein that is binding site to COVID-19. And that may be one of the explanations. But like I say, next month or next year, we may find other things. So what are other potential links between diabetes and COVID-19? The defects in innate immunity affects phagocytosis. They affect neutrophil chemotaxis and cell-mediated immunity. In order to gain entry to target cells, the SARS-CoV-2 or COVID-19 virus hijacks an endocrine pathway that plays a crucial role in blood pressure regulation, metabolism, and inflammation. So again, you see all these things, and these are possible factors that I think are associated with an increased morbidity and mortality in patients with type 2 diabetes that are affected by COVID. Inflammation, oxidative stress, endothelial dysfunction, hypercoagulability, with hyperglycemia, insulin resistant, more inflammation, more prone to infections, mechanism of defense are down, and the cargo of pathogens is significantly increased. And all these risk factors like thrombosis, affect morbidity and mortality. So glycemic control and viral infections, is our minority people, if you compare, A1C levels are usually higher than in Caucasians. So what has to do COVID-19, viral infections, and glycemic control? Well, hyperglycemia can directly increase glucose concentrations in airway secretions, okay? So where is the COVID-19 virus going? Into airways. Where do you inhale? Into airways. In vitro exposure of pulmonary epithelial cells to elevated glucose concentrations increases influenza, virus infections, and replication. If that is the same with COVID, we're going to have COVID-19 virus, and because of hyperglycemia and the increased concentration of glucose in these areas, we're going to have a replication of COVID-19 easier than in a patient that doesn't have diabetes. That suggests that hyperglycemia may increase viral replication in vivo. Hyperglycemia may also serve to suppress the antiviral immune response. These findings are consistent with studies of patients infected with highly pathogenic avian flu, whereby high glucose was associated with fatal outcomes. Then again, you put 1 and 1, and we're getting 2. Diabetes and COVID-19 is bad. So when I told you before, where are actually a lot of the cases, reported cases, of COVID-19? Well, there are actually in nursing homes and assisted living facilities. So in the US, if we look at nursing home and assisted living facilities, they accounted for 43% of COVID-19 deaths. Now, who lives there? Elderly people, people with disabilities, people with diabetes, usually not well cared, poorly controlled, and that is 43% of the deaths. Now, let's go back to other places. Here we have Louisiana, like I told you before, Michigan, and I have a little more numbers. Louisiana, African-American population is 32%, but 70% of the deaths due to COVID-19 were in African-American. In Michigan, 12% of the total population is African-American, but 40% of COVID-19 deaths were African-Americans. Obesity, diabetes, and hypertension are common comorbidities, and that's a big disparity. Similar to Texas, we have more Latinos here, and the Latinos have a higher proportion of morbidity and mortality, and obviously a lot more COVID infections. I went and looked at this data because these are physicians in the UK, okay? And the left-hand side is white physicians, okay? And deaths from COVID happen in white physicians at an age of 85. In the right-hand side is doctors of color. And the age where they died was 53 years of age. Is a 30-year difference in the deaths of these doctors in the UK. Now, let's go to Mexico, which is closer to us, okay? And if we look at data from Mexico, recently diagnosed diabetes have a higher risk of hospitalization and morbidity. Obesity accounts for a high risk of need for intensive care. The elderly, people older than 70 were more prone to have, COVID-19 and mortality. Chronic lung disease, patients in immunosuppression, and chronic renal disease. So again, you look at this, and it looks very similar to what we have. So I tracked this COVID tracking January 23rd, which is just a few days ago. And this is the hospitalization rates by race and ethnicity here in the US compared to Caucasians. African Americans, 1.4, which is 40% more. If we look at Latino Hispanics, 1.7, 70% more. This is only a few days ago, okay? And this is deaths per 100,000 people by race or ethnicity. So this is for African Americans, 149 for 100,000 people, Latinos 116, and Caucasians or white 91. Again, a big disparity in deaths in the United States by race or ethnicity. And this is a publication that came in the lay press, in hospital deaths from COVID-19, and more than half of in-hospital deaths from COVID-19 were among Black and Hispanic patients. That's what the study shows. Now, Hispanic is not the real name for us. I'm not a Hispanic, I'm a Latino. I'm come from Costa Rica, and we don't call ourselves Hispanics, we call ourselves Latinos. But in the US, the Census Bureau gave us that name, and some of us understand by that. But, the proper name will be Latinos. Let's talk about prevalence. This is October of 2020. In October of 2020, we have almost 8 million cases, 7.8. And we have 217,000 or 218,000 that died from COVID-19. So look at what happened from 7 million to almost 25 million, more than 3 times. But one thing that is, is still not a good number, but even though we triplicate or more the cases, the number of deaths were only 415,000. It didn't triplicate like the number of new cases. So in some instance, we're doing better. Now, the most effective states are California, Texas, Florida, New York, and Illinois. Unwanted consequences. Everybody thinks that, people only suffer from COVID and, they recover, they die, they have, but there are other unwanted consequences that we need to put attention to, okay? And this is, the Americas prior to COVID-19. 81% of deaths in the region prior to COVID-19 were due to non-communicable diseases, okay? 39% of these deaths were premature. And then we have the pandemic that interfere with routine care, drug acquisition, including vaccines. And to be honest with you, there was no time for proper planning on the care of individuals with NCDs by any health department anywhere in the world, maybe one exception, okay? But, advanced countries like European countries, the United States, Canada, we did not have the time or information to proper plan for the care of these individuals. And non-communicable diseases were associated with a high morbidity and mortality with COVID-19. Metabolic conditions such as diabetes, obesity, and hypertension, all of those aggravated by physical inactivity, increased alcohol consumption, overeating, or actually eating unhealthy. All were associated with higher risk of severe COVID-19, longer hospitalizations of those that survived, and more people died with these conditions. So controlling diabetes and controlling hypertension is essential, in these individuals. If we look at Americas and we look at patients in ICU, what are the conditions? Cardiovascular and diabetes. If we look at patients in ventilators, diabetes is much higher. And once you have a patient in a ventilator, the mortality is much higher because they're sicker people, okay? And what happens? Why did we have disruptions in care? Well, mixed messages from health and government authorities. Even agencies that should give us the pathway to what to do, there were mixed messages everywhere in the world, including the United States. Stay-at-home measures, we close so many things, and clinics, doctor's offices. So where is sick people going to go? Once they open, there was a fear of attending healthcare facilities. Why? Because they think that, if I go to a healthcare facility, I have a better chance to get infected. And then they were not taking the medications, they were not checking blood pressure, they were not checking glucose. So in addition to everything else, delay routine immunizations like the flu vaccine. If we look at PAHO in June 2020, they reported partial interruption of health services in 64% based on 18 surveyed countries in the Americas. 7% closed routine care completely. 25% remain open, but not with full services. And who were the most affected people? People with diabetes, people with hypertension, dental care, and rehabilitation services. So that's PAHO, June 2020. Confounding problems caused by the pandemic. Like I showed you before, cancellation of scheduled treatment, including routine immunizations by providers and then by patients. Aggravated by unemployment with loss of income and loss of health insurance. So people that were fired, didn't have any job, lost health insurance. Now, how will they get to ask the physicians for healthcare? And in addition to that, we have reduced social services. So if you look at this slide, the more severe the transmission phase of COVID-19 was, the more NCD services were disrupted. So if you look at, this slide, hypertension in phase 4, more disruption, diabetes, more disruption, cancer services, more disruption, and cardiovascular service, more disruption. So again, even in the phases that were not so difficult, disruption was there. So what are the new challenges for the non-communicable diseases agenda for the future, for the immediate future, in case something else happens? COVID-19 response compromise access to and quality of essential services for people with non-communicable diseases, already the leading cause of death, as well as time of immunization. COVID-19 infections may be associated with cardiac and renal complications, strokes, and clothing disorders. And in those not affected, staying at home cause a lot of psychiatric issues. COVID-19 may disrupt whole of society approaches to non-communicable diseases. disrupt medicine supplies, divert services, and complicate health messaging. People living with NCDs may experience more severe disease and poorer outcomes when infected. And various risk factors exist, such as obesity, smoking, diabetes, hyperglycemia. The more hyperglycemia, the more problems, and you're going to see now. Then what to do now? We need to move from a sole focus on COVID-19 and address the needs of the underlying drivers of morbidity and mortality. We cannot forget COVID-19, but we need to address, underlying drivers of morbidity and mortalities. Why? Because NCD kills 41 million people each year. Is 71% of all deaths globally, a lot more than actually COVID-19 at this present time. NCDs take a toll on the local economies by raising healthcare costs and loss of productivity. So most countries and counties have included non-communicable disease services in national COVID-19 plans, and they have prioritized services for the 4 major NCDs, which is cardiovascular, diabetes, cancer, and chronic renal disease. Telemedicine, is it the future? Well, I want to tell you, it is important because you know that we have actually done well with telemedicine in some areas. But if you look at this slide, high-income people actually do better telemedicine than low-income people. And when you start looking at Latinos that don't speak English, they really don't like and don't feel comfortable with telemedicine. In addition to that, not everyone has access to the internet and computers. You are seeing that with immunizations. Here in Dallas, some of the low-income areas were not vaccinated because they couldn't go to the computers and get access to immunizations. Preventive measures. I want to tell you something. I hope every one of you uses some cover. This is my cover. How many people have you seen with a cover talking to you and the cover is here? Not even the mouth, nor the nose. You need to tell them this is to cover your mouth, okay? And how many people have you seen that leave the nose outside and only cover the mouth? The proper way of using this is to cover your mouth and your nose, and this should be tied under your chin. How do you breathe? How do I breathe? Do I breathe through my mouth? No, I breathe through my nose. And we know that the accumulation of COVID-19 viruses is big here and big here. So if you cover the mouth only, you're not really protecting anybody. So don't be shy. If you see somebody just covering the mouth, I've seen that in restaurant workers, I've seen that in the pharmacies, I see that, we need to be taking care of ourselves and everybody else. Let them know that's not the way of doing it. So symptoms, and that's the reason you need to cover your mouth, because not every patient infected with the virus will develop symptoms. That's the big problem. And symptoms may take sometimes 1 to 14 days in appearing, and sometimes longer have been reported. The most common symptoms are fever, dry cough, diarrhea, and tiredness. Other symptoms, less common, are headaches, lot of smell, we call it anosmia in the vocabulary of medicine, and loss of taste, eugesia, okay? So if somebody doesn't smell anymore, or they try to eat something and it doesn't have a taste, be sure to let them know they need to be tested. And more recently, some unusual symptoms have been described, which is purple lesions in hands and feet, so they call them COVID toes. So any of those should be, an emphasis on getting testing. But most important is the prevention. I already told you. So we need to have more emphasis for high-risk people regarding recommendations issued by the CDC and other health agencies. Not your friend in the internet. not the TV station that tries to tell you what to do, and they have absolutely no idea what they're telling you. They're reading and they're translating something that sometimes is not correct. So the radio and TV and your friends, listen to healthcare providers. Listen to your doctors, okay? More than 50% of deaths occur in nursing homes, assisted living, correctional facility. So what to do there? We need to restrict visitors. We need to check the staff temperatures because they go in and out. And we need to actually check them for symptoms on a daily basis. As soon as everybody there can be vaccinated, better. We need to increase the space between workers. We need to enhance cleaning and disinfection. And that should be implemented in each facility as soon as possible. Residents should be also vaccinated. I have, some people that tell me, the parents are in an extended care facility, but they're not vaccinated. They vaccinated the staff, but not the residents. So I cannot understand some of these, deals that we have today. Wash your hands, is very important. Okay. Keep your distance is very important. Now we're going to go to patients with diabetes. This is from David Klonoff. It's very important to control glucose in patients with diabetes before they get COVID. In general, he says, bringing elevated glucose levels down to normal or near normal significantly improves a person's odds of surviving a serious hospitalization like COVID-19. So what has to do with glucose and viral infections? High circulating glucose levels increase the concentration of glucose in the tracheopulmonary secretions. In vitro, epithelial cells exposed to high glucose levels increase viral replication. So you have 10, you will have 20, you have 100, you will have 200, and that suggests that occurs in vivo. So hyperglycemia suppresses the immune system. Now we look at this, this is in the UK, and uncontrolled diabetes almost double the mortality versus the control. This is in 17.5 million with almost 6,000 deaths, and more males died, okay, older age, and diabetes increased that by 136%. Control was much better at 1.5. So diabetes by itself is, but uncontrolled increased that by 136% compared with no diabetes. What can we do? Well, treat underlying conditions properly. Hypertension, diabetes, lipids, everything that you have. Help your patients lose some weight. Keep them active. Maintain immunization schedules and updates. Be sure patients have medications for at least 3 months. In the beginning, people didn't have proper insulin, oral medications for diabetes, blood pressure pills, and that is a big disruption. It is essential for patients with diabetes to have access to self-monitoring of glucose, CGM preferred if it's type 1 diabetes and or in insulin. If not well controlled, please titrate or add medications to achieve the best possible control. And we have drugs today in type 2 diabetes that will allow us to do that without the risk of hypoglycemia or weight gain. So there is no antihypertensive nor anti-hyperglycemic agent, any of the drugs we use to treat these patients, that will increase the risk of contracting COVID-19. Therapies in use for COVID-19. In many countries, it's standard to use in patients recently diagnosed with symptoms, not really sick, hydroxychloroquine, 200 milligrams daily for 5 days, plus azithromycin, 500 milligrams in day 1, and 250 milligrams days 2 to 5. Not approved in the US, not FDA approved, but I know some people are using it. Remember, it's only of good use if we use it early in the diagnosis. If patients are significantly ill, it's not a recommended treatment. Dexamethasone, 6 milligrams orally and daily. If the patient is already on a ventilator, we still recommend dexamethasone, but it will be intravenous for 10 days. And these are not FDA approved, but we use them. Difference in mortality, 29.3% in the DEXA plus ventilator arm versus 41.4% in the ventilator without DEXA. That was published in the New England Journal of Medicine, July 2020. Remdesivir, 200 milligrams daily on day 1, followed by 100 milligrams daily for 9 days, a total of 10 cases approved by FDA in July 2020. Now, I'm going to show you a little interesting data. Vitamin D3 and metformin, and both appear to decrease the risk of hospitalization and death. So, medications. For patients that are awake, proper hydration is a must. Continue all medications used for diabetes, hypertension, lipids, etc. And we need to watch diuretics closely. We don't want these people to be actually dehydrated. We need to adjust the drugs for diabetes. If glucose levels not at target, we need to increase and act. If the patient is on a ventilator, intubated, they require IV fluids and they require insulin. Now, some facts. People in Italy that died from COVID-19 were vitamin D3 deficient. Similar findings in the UK, more cases and deaths in vitamin D3 deficient patients. That prompted healthcare minister to order to investigate further. So vitamin D3, 5,000 units daily may help, and there's no risk of harm at this point in time. Keeping physically and mentally active helps everybody. Sitting and watching bad news do not help. So again, we need to help our patients. Now, this is actually in the left-hand side, vitamin D clinical trials, and there are more than 25 that I found. I put some of there. The dose vary between 2,000 and even 10,000 units a day. So if you look in the right-hand side, those are new cases in Spain, southern Spain, Andalusia, after vitamin D, and new cases in the UK with no intervention. So you can see here in this is the intervention, and you see the new cases in Andalusia, Spain, going down. And this is actually the UK with no vitamin D going up. Now, this is Andalusia, and this is actually, the number of cases admitted to intensive care, and this is the number of deaths going down. So again, when you stop giving vitamin D3, things get worse. So it's something that will not harm your patients. You're not going to get for a few weeks of vitamin D3 anybody vitamin D3 toxic. So why not take it? But you as a physician or healthcare provider need to decide which one of your patients, especially in the winter when we really don't get enough sun, where most of us vitamin D3, vitamin D deficient. So this is a study from France. It's called the Coronado study. It's COVID-19 and diabetes outcome, 1,357 patients in 53 hospitals. And the study demonstrated that in metformin-treated patients, by day 7 of being hospitalized with COVID-19, survival rates were 41% more than those not using metformin. As you know, this study was not designed to address metformin as an endpoint. It was a secondary observation. Now we have 2 other studies, observational studies, one in Wuhan, China, and one at the University of Alabama here in the US. And again, both of those studies demonstrated that metformin lowered morbidity in patients with diabetes that were affected with COVID-19. In the Wuhan study, 3 died with metformin in the metformin group and 22 in the control group, equal patients. And University of Alabama, with 600 cases, the metformin, mortality was reduced by almost 70%. And that was adjusted to variables. Possible mechanism, weight loss, including ectopic fat, improving metabolic parameters, reduction in the inflammatory parameters, and inhibition in virus penetration via phosphorylation of ACE2 and inhibition of the immune hyperactivation. We're also using convalescent plasma in some places with great success, in some places not well, but the expanded access to convalescent plasma for the treatment of patients with COVID-19 may be an option. I don't know how many of you have seen these studies, with ivermectin. Ivermectin is a drug that we use to treat parasites, but there are some trials here, 35 trials, and they show that based on the studies, there is reduced morbidity, mortality, and you could potentially save about 11,000 lives. Vaccines. We have in the United States too, Moderna, FDA approved, is the one that was given to me. I have a little, local reaction. And the second shot should be given 28 days later. This is mRNA based, and Pfizer BioNTech, FDA approved with a second shot 21 days later. The difference between Moderna and Pfizer is transportation. The Pfizer requires a lot lower temperatures to stay active. But whatever you can take and whatever they give you, please take it, okay? It is very important for us to be vaccinated. In the future, in the United States, probably we have AstraZeneca, and more in the future, Janssen. There are other vaccines in phase 2-3. Melbourne University in Australia is an attenuated virus. Novavax is a nanoparticle. In Israel, the Israel Institute of Biological Research, has a vesicular from a stomatitis virus, but that is in phase 1. And as you know, China and Russia have other vaccines that are locally approved. And actually, I see that they're using it in some Latin American countries like Brazil and Argentina. So this is Pfizer and Moderna. You see Pfizer in the left-hand side. This is the time of the injection. As you know, it takes a few days for the vaccine to have activity. You still see some cases over time, but actually it's pretty good. You see here the number of days that it takes, to separate the curves. And this is Moderna. Again, this is the day they took them. This is the cases on those that didn't take the vaccine. And here, how well the two vaccines work in the prevention of COVID-19. So what else we need to do? Well, we need to have more emphasis on high-risk people, okay? And listen to the recommendation of CDC and proper health agencies. Don't forget, more than 50% of deaths occur in nursing homes, assisted living, and correctional facilities. Having a plan for these facilities is essential. We talk about restriction, everything we talked before should be actually part of the agenda. Now let's go and talk about vaccines and minorities, okay? We are a little resistant to take vaccines, but in 2019, the World Health Organization published the 10 major threats for public health. And that list included the anti-vaccine movement, the anti-vaxxers. So it is imperative that you and I and all of us educate our peers, the public, and our patients of the value, the significant value of vaccinations. A little facts on vaccines and diabetes. In patients with diabetes, vaccine-preventable diseases will cause hyperglycemia, require medication adjustment, extra visits, and sometimes hospitalization. That means suffering and expenses. People with diabetes have higher rates of most common vaccine-preventable diseases. Then why not use them? COVID-19 is an example. People with diabetes have an increased risk of complications and death from vaccine-preventable diseases. Remember, tell your people vaccines save lives and they're very cost-effective. There is a significant gap in vaccination rates both in African Americans and US Latino communities with important reasons. One of them, a recent example, is the antitrust. This is actually, from Xavier University, and some of the pushback came from parents of some students, and says, our children are not lab rats for drug companies. Because of that distrust, we're not actually vaccinating a lot of our people. And these are the CDC vaccine recommendations for all of us: influenza, pneumonia, hepatitis B, tetanus, diphtheria, pertussis, H-zoster, etc. But in 2021, COVID-19, actually at the end of 2020, COVID-19. People with diabetes have increased susceptibility to infection, genetic, metabolic, poor glycemic control. Those that have, in addition to diabetes, renal disease, cardiovascular disease, microvascular disease, and we get old enough, we have more propensity for these infections. The impaired mechanisms, antibody response, immune-mediated cellular response, impaired leukocyte action, colonization rate much higher. So unmet needs, it is a problem, okay? We can actually get ahead of the game, and it's our duty to make sure all patients with chronic diseases, including diabetes, get vaccinated. Risk of vaccines. Vaccines are extremely safe and offer significant health protection at a very reasonable cost. COVID vaccine is free. Secondary side effects are very rare, and if present, usually mild, like mine, Examples: light temperature increase, runny nose, or respiratory syndromes, and local reactions. You can live with that. No, I will tell you now the consequences of not getting the flu vaccine. You know the consequences of not getting the COVID vaccine. In the US during 2015-16, 56% did not get the flu shot. More than 1 in every 2 Americans did not get the flu shot. Why? I can't understand that. In the same period, 25 million people got the flu. And that resulted in 11 million medical visits at a cost of $10.4 billion, with 300,000 plus hospital admissions and 12,000 deaths, all preventable. My friends, it's time for us to do something. So in 2019, it was reported that those patients with diabetes who got immunized against the flu had some benefits as well. 30% less cardiovascular mortality, similar to taking a statin. So when we talk about cardiovascular outcome trials in patients with diabetes, remember, the flu shot appears to be very effective. Finally, conclusions. The big problem with diabetes is that we have all this intervention. They're multiple, repetitive, and persistent. But remember, in addition to everything else doctors do, we do eye exams, lipids, glucose, blood pressure. There are 2 things that actually sometimes we don't put attention to. One is vaccine, and the other is oral hygiene. In conclusions, COVID-19 has treatments and vaccines for prevention. Making sure that all Americans get vaccinated timely and properly by age, medical conditions, and other risk factors is a priority. Preventive measures to be followed as recommended by national, state, and or local medical authorities, not by lay people, not by TV, not by the newspapers, is by state, local, and national medical authorities. Thank you so much.
Thank you so much, Dr. Davidson. We actually have a number of questions in the Q&A box that I'd like to try to go through with you. Everyone seems to have found it a very exciting presentation. So if you don't mind, I'm going to just walk through the questions as they came in.
Okay, please.
And we had about 90 people on the call. So you've got a great audience. Here's question number one. Do you have any meaningful data about impact rate on refugees and immigrant communities?
Well, I don't have, actually, I look for that data and I did not get anything published that I could find, again, we have seen a few reports in the newspaper showing that, some of the immigration in some of the camps where we keep people, from getting out, in different places in the country, there were some outbreaks of COVID-19, but they didn't mention neither the percentage of people affected nor any more mortality. So, we need to keep looking for that data, which is very important.
Thank
But
you.
remember, Mexico has a significant number of COVID-19 patients, and obviously I understand from some of my my friends, physicians in El Paso, that, they want to come to the United States for treatment, because some of the hospitals in Ciudad Juarez are overwhelmed, and the question is, who do we treat first, our people or other people? I would like to treat everybody because, I'm an immigrant, but where do we set the goals? And it's very difficult. We need to get the whole world immunized, and hopefully that will happen sometime in the next 12 months.
Thank you. Another question is elevated platelet count above 500 a risk factor?
If you look at some data, in hospitalized patients that I have seen, it seems like, a high platelet count, it is a risk factor. And remember, some patients with diabetes that are dehydrated, they tend to have the problems with platelets and thrombosis. So yes, and that's the reason that some of these patients, were treated with anticoagulants sometimes, and the results vary. I think we have better treatments today, and there are some treatments that are quite interesting in big medical centers where they extract your blood and they put it back. I think that in the next few months we will know a lot more, but we have in less than a year progressed more with a disease like COVID that I could imagine.
Thank you. I think that's right. Another question. Wait, my question scroll is moving here. Dr. Davidson, do you have any data on the percent of hospitalized patients with COVID who did not know they had diabetes and the hyperglycemia was discovered during hospitalization?
Well, I want to tell you, I don't have numbers, but I can tell you there are many. And not only there are many, but those that were found to have diabetes, for the first time, like the data from Mexico that I show you, and some data here in the US, for some reason, they don't do well. So, they probably had diabetes before, but they were untreated, and we call it new onset diabetes in COVID. And I belong to a group of people worldwide that we're trying to actually look at what is the percentage of new onset diabetes in patients diagnosed with COVID. So that data will be available. The guy that is in charge is in the UK, is Dr. Rubino, and in Australia is Dr. Paul Zimmet, and I'm part of the group. I imagine you're going to see data, published not in the near future.
Okay, thank you for that. I'm moving around the questions, but I will make sure all the questions get answered working with Dr. Davidson. Patients with sickle cell disease or trait, are there any risks with COVID? The vaccine, was it tested? Do you have any knowledge about sickle cell and COVID?
Very, very little data. Some reports show no difference. And there's only one report that I went through but there's not enough number of patients to actually give you a proper answer. I will try to keep looking and see if there is a disparity there.
So another kind of related question is, you had kind of made the case that people of color have increased comorbidities and thus worse COVID outcomes. Are there data about people of color with no comorbidities in terms of their COVID risk and outcomes?
The data shows, that actually the death rate is very high in people and the morbidity with comorbidities, but it doesn't show that people that are, fit, trim, have an excess morbidity or mortality. So I imagine, that if we actually look at data, that we are going to see, no difference, in people of color and people Caucasians, if they are fit, they have normal body weight and no chronic conditions.
Thank you. Is there any data about the impact of COVID-19 on Afro-Caribbean community in New York and Brooklyn? And also, do risk found for people with diabetes apply to pregnant women with gestational diabetes?
Well, there are a few studies showing that pregnant women with, gestational diabetes, if they're well controlled, they fare well. There's no significant increase. Remember, these people are younger, they have less chronic conditions long term. So I imagine that, even though they have diabetes, they're not actually with the degree of inflammation and everything else that we see in the elderly people. And the first part of the question was in Asians?
Afro-Caribbeans.
Afro-Caribbean, no. Yeah, if you look, people from Puerto Rico, people from Dominican Republic that live, within the US, if you look at the reports from New York, if they have diabetes, they are overweight, they have actually a lot more morbidity and mortality from COVID.
We're getting to the close of our time. There's someone who wanted to ask, has there been a decrease in flu since the onset of COVID?
Absolutely. And the reason is that we are wearing the mask, and, maybe even, this really helped the transmission of the regular flu. But also, in addition to that, we didn't go out. How many people that usually get the flu, which are elderly, fragile, they didn't go out. They didn't, I have patients, that I follow, that they call me, even though I don't see them as patients in real life, that they haven't been out since last January. So if you don't go out and you don't interchange, and you are not going to have the number of infections like we used to see before with the flu. So yes, the flu cases this year were much less.
So this is a question that's near and dear to both of our hearts. How can we engage specialists to promote vaccination as a part of disease management and a standard of care?
Well, I think that, sometimes, the problem is time. I will tell you, I would love to tell you that, when we need to see a patient in 10 minutes with diabetes, that we have time to address the eyes, oral hygiene, the carotids, the thyroid, the heart, the lungs, food care. You cannot do it. And for some reason, like I say, oral hygiene, and vaccines are left for somebody else. So if it was me, I will go directly to the patients. I will actually do everything I can in TV, in newspapers, direct mailing every year before the flu, and tell people, these are the reasons why you need to be vaccinated. And then the patient will ask the doctor, you haven't, you know, I tell you, I did that many years ago. I did one video, you know, showing a patient asking, you know, I did it on purpose. I did a physical exam, but I didn't ask the patient to take off the shoes. Okay. But the patient, I said, well, I think we're almost finished. And the patient said to me, no, you're not finished. You haven't asked me to take off my shoes and my socks. So I think direct to consumers, direct to patients on vaccines, you know, not only the flu, COVID, pneumonia, all of those should be direct to consumers. And they need to learn and they need to ask for it.
That's great. It is 1 o'clock. There's a few questions that have to do with the rates of COVID in the States and obesity's influence and vitamin D's influence. I think they're in the slides, and the presentation will be made available to everyone. I guess we have a question if you're willing to be contacted by email, or would you like us to forward questions to you, sir?
You can give my email, you know, my email from the medical school is Jaime, that is jaime.davidson@utsouthwestern.edu.
Thank you so much. There's also a question about allergic reactions, so maybe we can follow up with that. Obviously, people were really so excited to have your presentation today, and what an honor to have your wisdom and knowledge. Thank you.
No, thank you. Have a great day. Have a nice weekend, and keep all the recommendations. Cover your nose, cover your mouth, distancing, and enjoy life. Go out and walk in the sun.
Thank you.
Thank you, everybody.
Yeah.
Thank
Thanks.
you.
Hey, thanks, guys. Thanks again, Dr. Davidson and Dr. Hall, for leading this presentation. I'm going to stay on for just a minute more, just because we put Dr. Davidson's email address in the chat box, so you can record that and then send him an email. Other than that, I hope you all have a great weekend, and I look forward to speaking to you again next weekend.
Thank you.
Bye-bye.
Bye. Thank you, Kate. Thank you, Brandon.
Thank you, sir.